Hello and welcome, and thank you for listening. I am Dr. Linda Vidone, and I am the current American Association of Dental Consultant President. This is very exciting for the AADC, the first ever AADC webinar, and hopefully many more to come. The Board of Directors envisions hosting 2 webinars a year, one in the fall and one in the winter, probably next February. The goals of these webinars are information, what's going on in our organization, what committees are working on, keep everyone motivated and engaged. We're a small organization, so we want everyone to get involved, and of course, provide continuing education. So when we first sat down to put the presentation together, we noticed AADC didn't have a presentation template, so we created one, of course, using the official logo. I know there is a lot of talent in this organization, so please feel free to create a template for AADC, submit it to the board, and there might even be a prize waiting for you. So the agenda today is during the upcoming hour, you'll meet the Board of Directors. I will then go over an overview of CDT and discuss the code changes for 2019, even share a few requests that were not approved. And just so everybody knows, the live version of this webinar was done October 4th. However, due to technical issues, we felt it best to re-record. I have no conflicts of interest in relationship to this presentation. I am employed by Delta Dental of Massachusetts, but for those of you that know me, they don't control what I say. I do my own research, literature, and presentations. Another disclaimer. Participation alone in this webinar does not allow for use of the code. CDT is a registered trademark of the American Dental Association. To use the CDT, a licensing agreement must be signed by the user and the ADA. There are different types of licensures available, so please go on to the ADA website regarding information on licensing. On behalf of the Board of Directors, thank you all for your continued support of AADC. We're a strong, sound organization, and it's really because of you. So here we are. Here is your board. I'm fortunate to work with a great team, and I do stress the word team this year. They hit the ground running right after the workshop in May, and I can assure you this board is extremely committed to our organization. However, of course, we couldn't do it without the support of our Executive Director, Ellen Kessler. Hopefully these faces look familiar. If not, introduce yourself to us at the workshop. All of our contact information is actually posted on the AADC website, or just look at the second page of the current issue of the Beacon. So let's start talking code. I'm going to begin with an overview of Dentistry's Code Set, Current Dental Terminology, abbreviated CDT. Starting with a brief history. The code was first published in 1969 in the Journal of the American Dental Association. So yes, it's almost 50 years old. And at that time, it was called the Uniform Code of Dental Procedures and Nomenclature. It consisted of 5 numbers and a brief name. Since 1990, the CDT has been published by the ADA and called Current Dental Terminology, as we know it today. First version, CDT-1, consisted of 5 numbers, a brief name, and only some codes had descriptors. Fast forward to 2000, the letter D replaced the numeral 0 as the first character of the procedure code. And the ADA made this change to enable the CDT code to be named as the HIPAA standard for reporting dental procedures, and to really differentiate dental procedure codes from CPT codes that are used by the American Medical Association. Therefore, any claim submitted on an electronic dental claim must use CDT dental procedure codes from the version in effect on the date of service of the claim. The codes also can be used on paper claims. And just a reminder, the ADA is the copyright owner and publisher of CDT. CDT code, like other code sets, it really provides standard information. So the purpose is to provide uniform, consistent, and accurate documentation of dental services delivered. It's really for 2 broad categories. 1, communication, to populate an electronic health record and standardized language for treatment planning, recording services. And then 2, payment, claim submissions, to provide for efficient processing of dental claims. the language of reimbursement. The ADA Council Dental Benefits Program is really responsible for maintaining the CDT in accordance with the ADA bylaws, policy, and federal regulations. Up until 2012, CDT was updated every 2 years, and the committee responsible was called Code Revision Committee, CRC, consisted of 12 voting members, 6 from the ADA, and 6 from major insurance carriers. As you can imagine, many dentists felt this was unfair and that the carriers had too strong of a voice. Well, the ADA has since refined the process, and as of 2013, CDT is updated annually, and the committee is now called Code Maintenance Committee, CMC. In order to fairly represent each sector of the profession, there are 21 members, including 5 from the ADA, 1 rep from each of the 9 recognized dental specialty organizations, 1 from the Academy of General Dentistry, 1 from the American Dental Education Association, and 5 from third-party payers. The CMC reviews each request and then votes to accept, amend, or decline a code change request. On occasion, a request is tabled. A work group is formed for further investigation and review. The original request is then reworked and considered again the following year, along with the work group's findings and recommendations. And many of you may remember, this is how Code 4346 came to be. Requests are separated into 2 categories, 1, substantive, and 2, editorial actions. Substantive actions include requests for a new code, a code to be deleted, or a significant revision of an existing code. Editorial changes just include grammatical or formatting changes to an existing code and really don't affect the definition or purpose of the code. Only accepted changes are incorporated into the next version, which is now effective January 1st yearly, not every 2 years. CMC meetings are really open to anyone who would like to attend. Dentists, hygienists, office staff, third-party payers, professional organizations, anyone can request a code change. Most submissions do come from dentists. There is only one CDT code request form, as you see on this slide. It's the same form for deletion, addition, or editorial changes, only a few pages long and relatively easy to fill out. The form and instructions are available for download on the ADA website. Just some considerations when submitting a request. Change requests should be based on the need to accurately document procedures performed. Nomenclatures, descriptors should be clear, concise, and not include time limitations. The request should not unbundle an existing procedure and not be specific to a trade name, technique, or instrumentation. Requests pertaining to newly developed procedures are encouraged to include documentation of clinical efficiency as well as supporting literature. Questions that should be considered: is the procedure taught in dental school? Is this procedure supported by the ADA Council of Dental Benefits? What about specialty organizations? Do they approve? So in other words, if it's a Perio code, you might want to reach out to the American Academy of Periodontology to see what they think of it. Will they support it? They might even give suggestions how to reword it so it does get approved. Timeline for code revision process. Request forms may be submitted to the American Dental Association at any time. However, the submission date determines when the request will be considered. As you see, code change requests for CDT 2020 are already due by November 1st, 2018, which is just next month. This slide shows the current timeline for CDT 2019. The CMC met earlier this year in March. Final decisions were sent to requesters in April. It's all posted on the website. The CDT manual is completed, and now they're working on CDT 2020. Throughout the previous slides, you probably noticed that a lot of the information I referenced, I kept saying, is on the ADA website. Well, everything you want to know about CDT is at ada.org/CDT. The left-hand side is well organized with hyperlinks to the forms, timelines, CMC meetings, licensing information. There's a glossary of terms, and so much more. And kudos to Frank Picorni and his team at the ADA, who do a wonderful job keeping this website up to date. I hope we all can agree that regardless of the carrier we work for, our mantra is the same. The existence of a code does not imply that it will be a covered dental procedure by a benefit plan. Dental benefit plans are required to recognize all CDT codes, but are not required to provide reimbursement for them. The treatment plan should be developed according to professional standards and not according to provisions of a contract. Treat the patient, not the plan, we state. Specialists and general dentists must use the same code set. And then veracity, simply stated, means truthfulness. This concept is so important it's incorporated into the ADA's Principle, Ethics, and Code of Professional Conduct. Code for what you do. I will now go over CDT 2019 changes. I'll explain the definition of the codes and rationales, but I am not going to discuss recommendations or guidance how you or your company should benefit the codes, nor will I discuss fee guidance. Over 70 requests were submitted and reviewed, voted on this year, but the CMC only approved 26 changes, which included 15 new codes. 4 codes were deleted. However, they were replaced with new codes to provide the greater specificity for documentation. 5 codes were revised, and 2 codes had editorial changes. For a complete list of all the changes, it's essential that you buy the CDT 2019 manual. I also highly recommend purchasing the companion book. The ADA, over the past few years, has done a great job revising this book with important supplemental information about the codes themselves. My favorite chapter is the implant chapter. And then, for a few dollars more, you can receive the mobile app. Personally, I use this all the time. These 2019 books are already available, and you can order them on the ADA website at adacatalog.org. I'm now going to go through the changes, and anything in red that I referenced has been deleted, and blue has been added. So there's been one new code added in the diagnostic section. Just last year, 2018, code D0411, A1C Office Point of Service Testing was added, which measures a patient's blood glucose control over the past few months. However, even though a patient's A1C may be in control, the patient's blood sugar at any specific moment may actually be very low, which can lead to a hypoglycemic event, or even it could be too high. And about half of the diabetics don't adequately control their blood sugar levels. If a diabetic patient, say, is about to undergo a complex procedure, the dentist really should know what their blood sugar level is at that time. And this can be done with a glucose meter prior to the procedure. And if the patient's blood glucose sugar level is below 70 milligrams per deciliter, best not to perform the procedure since a hypoglycemic event is likely to occur. On the other hand, if it's over 300 milligrams per deciliter, best not to perform the procedure since this could lead to delayed healing. Well, this new code, D0412, blood glucose level test in office using glucose meter. This procedure provides an immediate finding of the patient's blood glucose level at the time of sample collection. So currently, if a dentist is performing this test, most likely they're submitting it as D0999. Both tests are needed to ensure good diabetes management in the dental office. One is not better than the other. And this shows medical-dental integration and encouraging interprofessional collaboration between dentists and our medical colleagues. Diabetes is a very expensive disease to treat. In the U.S., we spend $245 million a year on diabetic treatment. And it's often referred in this country as a diabetic epidemic. Changes in the preventative section. Well, these changes were submitted by NADP, the National Association of Dental Plans. The current code, D1515, bilateral fixed space maintainer, was not arch specific. In many cases, claims were received for 2 codes, D1550s. This led to frustration for providers since us carriers would have to request additional information to determine was it an error, was it a duplicate service, or if indeed they were being performed on both arches. Well, the request often involves a manual process which delayed claims, and for the providers and for the carriers, it was more work. Therefore, D1515 was deleted and replaced with D1516, Space Maintainer Fixed Bilateral Maxillary, and D1517, Space Maintainer Fixed Bilateral Mandibular. These provide the needed clarity to auto-adjudicate the claim. So thank you, NADP. Same rationale and concept applies to the removable bilateral space maintainer. D1525 bilateral removable space maintainer is deleted and replaced with D1526 space maintainer removable bilateral maxillary and D1527 space maintainer removable bilateral mandibular. Once again, these codes define which arch the space maintainer was placed and facilitates auto-adjudication. There were no code changes in 2000 series, the restorative series, and the 3000 endodontic categories. Two editorial changes for CDT 2019 are here in the Perio section, once again submitted by NADP. These changes will make the language of D4230 and D4231 anatomical crown exposure consistent with language in D4210, D4211, D4240, D4241, D4260, and 61. That is the gingivectomies, flap, and osseous surgeries. It's really just where you put the word tooth. Making it more understandable did not change the definition of the code itself. 3 out of the 5 revisions are here in the removable prosthetic section, submitted by a personal friend of mine and a longtime AADC member, Dr. Doyle Williams. D5211, maxillary partial denture resin base, and D5213, mandibular partial denture resin base. As you see, the nomenclature was revised, the descriptor deleted. The rationale was that conventional clasps are really part of the denture base or embedded in it. They clasp a single tooth. While flexible gasket material like silicone could be added to a partial denture and envelopes multiple teeth in the area. The addition of this material as a class type identifies it as a single class for reporting purposes. So a clinical scenario would be a patient presents with mobile teeth that a conventional clasp would not engage sufficiently. A partial denture is completed with open areas around the teeth that are unstable for conventional clasping, and a flexible gasket or silicone is thus added by the lab tech. So for consistency, the same concept and rationale applies to D5630, repair or replace broken clasp. The nomenclature was revised. For these 3 codes, the definition of the code itself hasn't changed, just really clarifies the material. Thank you, Doyle. Submitted by NADP, 5281, removable unilateral partial denture, one-piece cast metal, including the clasp and the teeth, has been deleted, and as you see, replaced with D5282 and D5283 with mandibular and maxillary designations to increase granularity, and it really brings this code in line with the rest of the codes in the partial denture section, all of which differentiate between maxillary and mandibular. This helps to facilitate auto-adjudication, which we all know us as carriers do appreciate. Another submission by Dr. Doyle Williams. This is a new code, D5876. Add metal substructure to acrylic full denture per arch. It's to be used when fabricating a new denture. It's in addition to a new denture and not for a repair of an existing appliance. The metal substructure would be embedded into the denture and can be applied in either arch. The goal is that if a metal substructure is added to a full acrylic denture for patients at high risk of breaking their denture, such as ones that are bruxism or they have disabilities or other factors, it really adds that additional strength and helps prevent the denture from breaking. Currently, there is not an existing code that describes this procedure, so it's being submitted with unspecified D5899. Which requires a narrative and lacks the ability to be auto-adjudicated. There were no codes in the 6000 implant or the 6000 fixed prosthetic sections. There was a revision in the oral maxillofacial surgery category. However, it was submitted by the American Academy of Orthodontics. So for code 7283, placement of a device to facilitate eruption of impacted tooth, in the descriptor, the phrase orthodontic bracket, band, or other device was eliminated and replaced with the word attachment. This demonstrates that this procedure can be done for purposes other than orthodontics. And the rationale was that some carriers see the word orthodontic in the descriptor or nomenclature, and they automatically deduct claim payment from the orthodontic coverage, although no orthodontic treatment was ever performed, thus utilizing the patient's orthodontic lifetime maximum. So clinical scenario of this procedure is after surgical exposure of an unerupted tooth, an attachment is placed, typically bonded on the tooth to aid in its eruption. Orthodontics may not be done to achieve this eruption. For example, attachments can be placed on the mesial impacted permanent first molars that are trapped by a deciduous second molar. The attachment is designed just to unlock the permanent first molar and allow for normal eruption. There were no changes in the 8000 orthodontic section. So the last section is adjunctive general services. This new code was submitted by the ADA Council of Dental Benefits. D9310, temporomandibular joint dysfunction, non-invasive physical therapies. The descriptor states therapy, including but not limited to massage, ultrasound, or cold applications to provide relief for muscle spasms, inflammation of pain, intending to improve freedom of motion and joint function. This should be reported on a per-session basis. So currently, we have CDT codes that allow for reporting of invasive TMJ dysfunction procedures, such as surgical procedures, D7810. There were no codes for just a conservative, non-invasive TMJ physical therapy procedure. Currently, if these non-invasive procedures are performed, the CDT code being utilized is an unspecified procedure by report. So a clinical scenario would be the patient presents with a complaint of limited jaw motion and pain when the jaw moves. An oral evaluation indicates that patient suffers from TMJ dysfunction. The patient's treatment plan is conservative, beginning with non-invasive therapy before oral appliance or surgical treatment are ever even considered. Next code, the current code D9219. Nomenclature implied that pre-delivery evaluation is only needed for patients who will be deeply sedated or under general anesthesia. There was no compatible code for moderate sedation. So D9219 has been revised to include evaluation for moderate sedation. This request was submitted by the American Academy of Oral Maxillofacial Surgeons. D9613. Infiltration of a sustained release therapeutic agent, single or multiple sites. Infiltration of a sustained release agent for long-acting surgical site pain control, not for local anesthetic purposes. So no, right in the nomenclature, it doesn't matter whether it's one or multiple sites being performed. With the enormous focus in the U.S. on the opioid epidemic, patients, lawmakers, they're all requesting that dentists use non-narcotic alternatives for post-operative pain control. This code will actually describe the use of an FDA-approved non-opioid medicine to relieve pain. Clinical scenario. Patient presents for removal of impacted wisdom tooth. And as part of the pain management protocol, a sustained release agent will be used at the end of the procedure to provide long-lasting pain control. In other words, the patient will be numb, thus reducing or eliminating the need for a dentist to write a prescription for opioids. After completion of the extractions, the surgical site is infiltrated with this agent. An example of this agent is Exparel. Some of you might have heard of it. Just as a side note, Dr. Tillman informed me that the manufacturers of Exparel might even be at our AADC workshop in May, hopefully to give us more information about this drug. Submitted by the NADP, code 9940, occlusal guard by report has been deleted to create greater granularity, and specificity within the code, and thus eliminates that need for a by-report procedure. 3 codes have been added to replace D9940. The first code, D9944, occlusal guard hard appliance, full arch. Descriptor reads, removable dental appliance designed to minimize the effects of bruxism or other occlusal factors, not to be reported for any type of sleep apnea, snoring, or TMJ appliance. D9945, occlusal guard soft appliance, full arch, same descriptor as D9944. The last one, D9946, occlusal guard hard appliance, partial arch. Well, it's the same descriptor as the first 2, but provides only partial occlusal coverage, such as an anterior deprogrammer. Another submission by Dr. Doyle Williams, D9961, duplicate copy of the patient's records. I think we all know it's performed when a patient requests a copy of their records, if they're going to switch dental offices for personal use, or even for when a physician requests a copy. The dental office must prepare a HIPAA-compliant record electronically or manually, which, if you're doing it manually, does take time. However, with the advent of digital x-rays and electronic health records, the time spent has really decreased. So D9961 will be used to document this activity, and it makes sense that it was placed really in the non-clinical procedures area, along with the sales tax, the missed appointment, etc. And keep in mind, there might be state laws associated with the limits on what a provider can actually charge a patient. One word of caution, this code is not to be submitted by a dentist when an insurance carrier requests information such as radiographs or treatment records for review of claims in utilization management or utilization review for a compliance audit. So it could have potential for misuse and abuse, so I recommend your company be on the lookout for this code. The final code change for CDT 2019 is D9960. Delta Dental Plans Association, DDPA, submitted the request for the new code D9960, Certified Translation or Sign Language Services per visit. This translation occurs in person. With the implementation in 2016 of the Affordable Health Care Act, Section 1557 regarding non-discrimination, there's a requirement for covered entities to provide language services to people whose primary language is not English. DDPA felt the translation service really warrants its own code to improve efficiencies and benefit determination. So currently, translation services is only part of a very long list of services within that code D9994, the Dental Case Management Code, which includes patient education as well as other things that need to be translated, and really not just for the translation services itself during the actual dental visit. There's no means for an office to indicate that just that service had been reported and performed without requesting additional information. So having a dedicated code improves processing efficiencies and enables benefit determinations to be made without additional information. And this really is good for not only providers, but also for us third-party payers. A large number of code requests are submitted each year, and only really a handful make the cut. Reviewing denied code requests is helpful. It gives insight into the thought process, what the dental community is thinking of, and also the thoughts of the CMC, why a request was denied or tabled. I will now discuss a few requests that didn't make the cut for 2019 and the CMC's rationale why. The full list, however, is posted on the ADA website. So this code was submitted by the Dental Hygienist Coding Focus Group to revise code D0150. The request to remove the words used by a general dentist and or specialist when evaluating a patient comprehensively. So they state that medical CPT codes are used to describe really a medical procedure itself and are used by many practitioners. There's no distinction as to what healthcare provider can perform a procedure as long as they're practicing within the scope of their state law. This group felt CDT codes should parallel medicine and should not be limited to dentists only. Well, the CMC did not accept this change. The rationale was a dental diagnosis and treatment plan can only be performed by a dentist by virtue of his or her education and training. This request from the American Academy of Pediatric Dentistry to delete existing codes D1110, Prophy codes for adults, and Prophy code for a child, D1120. And they wanted to create one code for prophylaxis. They state there are many problems with the current Prophy codes, such as both descriptors describe the procedure with the same words, and includes a transitional dentition. They went on to say that the term transitional dentition in and of itself is rather ambiguous. Well, these requests were not accepted by the CMC, which notes they potentially are problematic and not a real working solution to the problems postulated by the submitter. Another submission. They state that the current nomenclature for Prophy codes fails to define an adult or a child, as is commonly done by an age. They recommend that these codes include an age. So an adult would be age 14 or older, because that's when really most patients have their permanent dentition. Well, these revisions, once again, were not accepted by the CMC. In fact, the proposed changes may actually create new, unanticipated problems, and that the existing Prophy codes are understood by dentists and others in the dental community. These codes were submitted by NADP. Oftentimes, after an indirect restoration, such as a crown is placed, a root canal is performed and the access cavity is minimal. The crown doesn't need to be replaced, only closure of the access cavity. And we all know that's usually done with just a single surface amalgam or composite. However, the restoration is denied by carriers many times due to the fact a crown is in a patient's history. Well, this code will allow the restoration to be auto-adjudicated without the request of additional information. Well, the CMC found that the submission documentation really doesn't establish the need for a new CDT code. And they cited that, hey, claim auto-adjudication conundrum could be resolved with the use of patient claim history. Another submission by the NADP, this request was for root canal therapy on primary teeth without a permanent successor, one for anterior teeth and one for posterior teeth. So currently, primary anterior tooth that needs a root canal is submitted but doesn't have a successor as D3310. In fact, under the text, the subheading endodontic therapy in the CDT manual, it states that D3310 to D3330 includes primary teeth without a successor. However, most of the time when D3310 is submitted on a primary teeth without a successor, they are denied. There's no way for an insurance carrier to verify if the primary tooth has a successor or not. So this way, the CDT code for this clinical condition would allow for more precise reporting. Well, the American Academy of Endodontics did have concerns. So the submitter, NADP, stated they'll work with the endodontist to address their concerns and questions and then bring potentially a replacement action request for the CMC meeting in March 2019. This code request is for an implant-supported porcelain fused to metal crown, noble metal. Well, the current code, D6066, states implant-supported porcelain fused to metal crown, titanium alloy, high noble. However, it didn't include noble alloy. So the American College of Prosthodontics, a CMC member, intends to review how all the CDT code entries for prostheses, especially in the implant-supported crowns, cite materials, and now will prepare an action request for consideration during the March 2019 CMC meeting. A request for a new code, osseous, osteoperiosteal, or cartilage graft of a single site in the mandibular or maxilla. The new code being proposed would be used for a single site graft where a tooth was lost previously, at least 6 to 12 months, and the area is now being grafted to support a future implant, but is not at the time of extraction nor at the time of implant placement. Well, the CDT determined, and I'm sure you're all thinking the same thing, that the procedures described in the action request may appropriately be reported as the current CDC D7950, osseous, osteoperiosteal, or cartilage graft of the mandibular or maxillary, autogenous or non-autogenous by report. And it goes on to state this procedure is for ridge augmentation or reconstruction to increase height, width, or volume of residual alveolar ridge. It includes obtaining graft material. Placement of a barrier, if used, should be reported separately. So basically, it's the same thing. The request is the same thing as the current D7950, which is why it was rejected. Submitted by an oral surgeon to revise D7250, surgical removal of residual roots that the carriers request additional information, because initially it was the initial submission would be surgical removal of residual roots. They request to add the language remaining root structure following the loss of the major portion over 75% of the crown. The rationale being that insurance carriers look at the definition of D7250 as a root that is covered by gingival tissue completely, even though that is not part of the definition. So the definition they felt is incomplete, ambiguous, and leads to misinterpretation by us carriers and providers. Well, the CMC stated that the proposed nomenclature revision is to a pre-CDT 2017 version of the code, and that inclusion of percentages in a nomenclature is a retrograde action that adds confusion, and that the current nomenclature entry D7250, removal of residual tooth roots cutting procedure, is more than satisfactory. Another submission, and last one I will discuss, by the Dental Hygienist Coding Focus Group. Local anesthetic, they understand, is usually considered to be part of procedures. However, they assume that this is injectable, and there is no procedure code for application of non-injectable adjunctive agents. These agents can be used in conjunction with injectable local anesthetics or as a standing-alone procedure. Well, the CMC stated the procedure, as you read here, describes an anesthetic delivery technique that it really can be reported with the existing code D9215, local anesthetics in conjunction with operative or surgical procedures. Techniques used in delivery of local anesthetics, such as injectable or topical, should not be unbundled from the procedure as described in the current CDT code entry. So this concludes our presentation today. The board recognizes how valuable your time is, and we thank you for attending. If you have any questions in regard to this presentation, please, my contact information is listed, as well as you can contact Ellen Kessler. If you have listened and you do desire to receive a continuing ed credit, please email Ellen Kessler and be sure to fill out the survey that she sends you. For those that are not members of AADC, please go to our website, aadc.org, to learn more about the information about our wonderful organization. Again, thank you, and stay tuned for our next webinar in February. And I look forward to seeing all of you next May at our workshop. Have a safe, wonderful holiday season. Goodbye.